我個 talk 咧就係 Endocarditis in Childhood，咁呢個就係我 objective 啦。我會share 一個 case 啦 and then we'll discuss 點樣 diagnose infective endocarditis, what is the management, and then I will go back and talk about the scope of the problem and a little bit about SBE prophylaxis. 因為咧喺 SBE prophylaxis 係有 guideline change 過，我唔知你知唔知啦，2007至2008年嘅。And then what is the impact of these guideline changes and what are the current guidelines? So let's start off with the case. 呢個係一個12歲女仔 She's had a 1-month history of fever on and off. 佢嘅 symptoms 咧就係 occasional headache, dizziness, neck and upper back muscle pain during fever. And she has coryzal symptoms and sometimes urinary symptoms. And she has actually been seen by her family physician and he treated her with short courses of oral antibiotics. Initially, 就係 for URTI 啦 and then 就係 for urinary tract infection. And each time, the fever will subside, but it recurs 24 hours after stopping the antibiotics. In the second visit, this family physician, who has been seeing her since she was a young baby, detected a new heart murmur. And so he referred her to an outside hospital clinic. Subsequently, because she keeps having recurrent fever, she was admitted to an outside hospital. At that time, she had a mild cough, no shortness of breath. She does have polyuria, occasional tinnitus, no rash, no diarrhea, no chest pain, no palpitation. And so these are the other history. So in her past medical history, she was apparently noted to have a heart murmur when she was 2 months old. And the parents were told that the echo at the time was normal. And in the past, she's had occasional tinnitus and headaches, hasn't really been seen by anybody. The family history is really very unremarkable. No congenital heart disease, no sudden death, no arrhythmia, no aortic dissection, no connective tissue disorder. Her medication, she's been taking the antibiotics by the primary physician. Otherwise, she does not take any medicine. She has no allergies, and she's up to date with her immunization. She has not had any recent travels, no recent dental surgeries, and no injuries. On exam, she is febrile, 38'6". She is average for weight, and she's quite tall, 90 to 97th percentile. And you will note that her arm span is taller than her height. She was tachycardic, 130 beats per minute, and her blood pressure is normal. And she looks a little bit morphinoid. On cardiovascular exam, her apex is not displayed. She has a normal S1, normally split S2, and a 3/6 pansystolic murmur at the apex radiating to the axilla, suggestive of a mitral valve problem. She has 2+ femoral pulses, no peripheral edema. Her lung exam is normal. She has no pectus deformity. Her abdomen is soft, no hepatosplenomegaly. In her peripheries, she has normal cap refill, no rash, no splinter hemorrhages, no clubbing. And interestingly, she does have arachnodactyly. This, I have to admit, is not from her, but hers actually looked very similar. And her wrist sign was positive, but her thumb sign was negative. So I looked in her mouth. She had no dental caries and no high arch palate. So we did do some labs. Her CBC showed that she has elevated white count, predominantly neutrophils. Her CRP and her procalcitonin are both elevated. Her renal and liver functions were normal, and her coagulation profile was also normal. Her nasopharyngeal aspirate was negative, her urine dipstick was negative, and urine culture was negative. So we did take 3 sets of blood cultures. This is her chest X-ray. She has a normal cardiothoracic ratio, and you can see a normal cardiac silhouette. But there is mild increased pulmonary vascular markings everywhere. And by chance, she also has a normal left-sided aortic arch here. of course, I have to show you her ECG. So her ECG shows she has sinus tachycardic, but importantly, her PR interval is normal, and there are no ST or T wave abnormality. And so this is, apart from sinus tachycardia, this is a very normal ECG. So these are echocardiograms. So on the left 4 is the apical 4-chamber view, and on the right is the parasternal long and short axis view. So if you look at this is the apical 4-chamber, and you can see normal LV and RV function. And you can see that, well, if it was moving, you will see that there is a mass in the mitral valve here, and this is a still frame, and it shows the vegetation on the anterior mitral valve leaflet measuring 0.6 to 1.3 centimeter. This is the, again, if it was moving, you can see that there is moderate mitral regurgitation that goes back to the left atrium. In the parasternal short axis, long axis view, you can see again mitral regurgitation, and there is a gap in the mitral valve leaflet here. And again, in the short axis view, if it was playing, you will see the mitral regurgitation. Again, this is the gap between the anterior mitral valve leaflet, causing the mitral regurgitation. So what is the preliminary differential diagnosis? She looks like she has infective endocarditis of the mitral valve with a vegetation. Could she, because with the Marfanoid signs, can she have an underlying undiagnosed connective tissue disease with infective endocarditis of the native mitral valve? Maybe. And could she have maybe rheumatic heart disease? It's rare, but that can happen. So that leads me to think about, so how do we diagnose endocarditis? I think that you have to have a high index of suspicion, someone who has prolonged fever and new heart murmur. And I think that this is where continuous assessment by a single primary care physician is very important. And remember, this primary care physician noted the new heart murmur. Now, he thought because it's a new heart murmur, just go to a local cardiac clinic. I think as time goes on, probably he should reflex and refer earlier to our cardiology clinic to be seen because of the fever and the new murmur. So I think that's a very astute primary care physician. And that will only happen if you have been seeing this patient since they were a little child. So what are the criteria for diagnosing infective endocarditis? So remember the Duke criteria, right? So now there is the modified Duke criteria. So for definite infective endocarditis, you have pathological criteria and clinical criteria. For pathological criteria, you need to demonstrate microorganisms by culture or histology in the vegetation or an intracardiac abscess, or a pathological lesion which is a vegetation or intracardiac abscess present, confirmed by histology showing active endocarditis. So that means most of these are done surgically, right? So how do we decide clinically? So we use the clinical criteria. That means you need to either have 2 major criteria or 1 major, 3 minors, or 5 minors. So what are these criteria? So in the AHA 2015 and the European 2015 guidelines, the major criteria are basically the same. So you need to have blood culture, and you need to have a typical organism growing from at least 2 blood cultures. So it can be the Viridans streptococci, Strep bovis, or the haystack group, or a community-acquired Staph aureus, or enterococci in the absence of a primary foci. or organisms consistent with infective endocarditis with persistently positive blood culture, defined as more than 2 blood culture more than 12 hours apart, or 3 out of majority of the blood culture, irrespective of the timing, or if you have 1 positive blood culture of Coxiella burnettii or antiphase 1 immunoglobulin antibody titer. So what about the other evidence? So this is where the AHA and the European guideline differs a little bit. In the AHA guideline, they said you have to have a positive echo. So you obviously will start with a transthoracic echo. If it's ambiguous, then you need to go to a transesophageal echo. And what we are looking for is oscillating intracardiac mass on the valve or supporting structures or on an implanted material in the absence of alternative anatomic explanation. What does that mean? That means that if you have an implanted valve and all along they have a very echogenic material underneath the valve, then that is not a new finding. And so this really means that you have to look back at all the other echoes. Or if you see an intracardiac abscess or new partial dehiscence of a prosthetic valve or new valvular regurgitation. In the European guideline, apart from the echo, they also use advanced imaging. So they are looking at either using PET-CT or the SPECT-CT, or you can look for diffuse paravalvular lesion by the cardiac CT. So for minor criteria, again, this is the same for both. Do they have any predisposition for predisposing heart condition, or they are IV drug user? They have fever greater than 38 degrees, or they have some vascular phenomenon. What do they mean by that? Do they have any septic emboli, mycotic aneurysm, intracranial or conjunctival hemorrhage, or maybe Janeway lesion? So Janeway lesion are hemorrhagic lesion. So they're non-tender hemorrhagic papules from septic emboli. Or do you have an immunological phenomenon like glomerulonephritis or maybe Osler's node or Roth spot in the eye? Osler node is a tender nodule from the immune complexes. And then the Roth spot, you can only see it by ophthalmological exam. And then microbiological evidence. So positive blood culture, but doesn't meet the major criterion as noted above. And I think in the ESC guideline, they also have a very nice table to say if you have clinical suspicion of IE, what do you do? So that means you need to get an echo, and if you have an echo, what does it find? You may need a transesophageal echo, etc. And if you suspect someone have infective endocarditis, if you're not a cardiologist, you can still do things. You need to first take a blood culture before you give them antibiotics, and then you go down the tree. And if the blood culture doesn't help, you can maybe look for serology. And nowadays, you can even use more advanced technique like blood PCR or specific PCR to look for these organisms. And this will come in handy later on as we talk. So back to our case. All 3 of her blood cultures grew gram-positive cocci in chains, and they are Ambiotrophia defectiva, and is sensitive to penicillin. And you may say, what is that? That is exactly my response too. I'm like, what is Ambiotrophia defectiva? And so we will talk a little bit about that. And so luckily, all her subsequent blood cultures after treatment were negative. She had no Roth spot, no lens dislocation, because remember, I worried about Marfan. On dental evaluation, she has no dental caries, fair dental hygiene, and we also consulted genetics. So if we look back at the criteria, She has typical microorganism for IE in more than 2 blood culture. So that's one major criteria. And she has new valvular regurgitation because supposedly her 2-month-old echo was normal. So she already has 2 major criteria. So she definitely has endocarditis. So we treated her with IV ceftriaxone for 2 weeks. Unfortunately, she developed liver derangement. And so we have to switch to cefotaxime for 2 weeks. And she had drug fever with a rash, eosinophilia, leukocytopenia. So we finished the last 2 weeks with vancomycin. Because of the moderate mitral regurgitation and left atrial enlargement, we also started her on lisinopril. And she is now an outpatient, and we have already scheduled her for an elective mitral valve replacement. So what is Amyotrophia defectiva? So both Amyotrophia and Granulocytella species, they are formerly known as nutritional variant strap, so NVS, or nutritional deficient strap. They are very fastidious gram-positive cocci, but they are normal constituents of your human oropharyngeal, GI, and urogenital flora. But it does account for 1.2 to 8% of all cases of infective endocarditis. It is also associated with other invasive infection, such as abscess, wound infection, and meningitis. So it can be challenging to grow them. So we were very lucky because she's already had oral antibiotics. And so they may actually constitute some of the culture-negative infective endocarditis. So if you do antimicrobial susceptibility testing, you may be able to find that. But this is very challenging for clinical lab because they really have to use the patient-specific serum and see if they can use different types of antibiotics and what the curve is like, and it's quite labor-intensive. Another way for culture-negative IE that they can do is they can use molecular method. So they use a 16S-PCR sequencing from the blood culture isolate, and they can use the direct valve or prosthetic material to find this organism. Since 2019, a lot of labs actually do this MALDI-TOF mass spectrometry. So you can see the long name there from blood culture. And using that, they can easily identify the Amyotrophia. So the treatment, as recommended by both AHA and BSAC, is benzalpenicillin or ampicillin plus gentamicin for 4 to 6 weeks, or vancomycin alone for 6 weeks. So 33% of the nutritional variant strap are susceptible to penicillin. So not very good, right? But they are very susceptible to the 3rd generation cephalosporin like cefotaxime and ceftriaxone. And in fact, Amyotrophia, 94.6% are susceptible to cefotaxime and 100% to ceftriaxone. So those were the rationale for the antibiotics that we used for her. And luckily, Amyotrophia lack high-level aminoglycoside resistance. So they are also they are good. Gentamicin can be a good synergistic antibiotic, and they are all susceptible to vancomycin. So the outcome, even though they seem to be easily treated, they can have poor prognosis, frequently resulting in large vegetation, causing valve destruction and heart failure. And so they are at a high risk of systemic embolization, and cardiac surgery may be needed in up to 70% of the case. So when we treat infective endocarditis, we do need to give them a prolonged course of IV antibiotics, a minimum of 4 weeks, and often is 6 to 8 weeks, depending on how well they respond to it. And we prefer to use bactericidal agents over bacteriostatic drugs. Antibiotic selection obviously based on the susceptibility of the bacteria. And we need to really monitor them for complication and for antibiotic treatment complication like in my patient. So we look out for embolic event, any progressive enlargement of the vegetation, development of perivalvular abscess, conduction abnormalities, and congestive heart failure. And so there are certain patients that may have higher risk for infective endocarditis complication. If they have prosthetic heart valve, left-sided IE like an outpatient, Staph aureus IE, fungal or previous IE, prolonged clinical symptoms, and what I care about, my cyanotic congenital heart disease, patients with systemic to pulmonary shunt, and poor clinical response to antimicrobial therapy. And in the ESC guideline, you can see that there are also other factors that indicate poor outcome. So older age, diabetes, comorbidity, if they have heart failure, renal failure, brain hemorrhage, septic shock, Staph aureus, fungi, and non-Hay-Sac gram-negative bacilli, and other echo findings. So when would we consider surgical intervention? So you can divide that into vegetation, valvular dysfunction, and perivalvular extension. And so for our patient, she has a vegetation that's greater than 10 millimeter. Luckily, it didn't progress, and she doesn't have any significant systemic emboli, and her heart failure is under management. So she can have an elective surgical intervention. So what is the scope of this problem? So actually it's more common than you think. Even though the incidence may be 0.34 to 0.64 cases per 100,000 per year, we have seen 2 in the recent 3 months. And it can be up to 25% mortality in cases of native valve endocarditis. And the risk factor for IE in the 1970s, almost half of them is because children has rheumatic heart disease. But as rheumatic heart disease become rarer, congenital heart disease patient is the number 1 cause. And they have 15 to 140 times the risk of developing IE with increased mortality. And then other patient group are those who are immunocompromised, or if they have foreign material, like indwelling catheters, central lines, surgically placed shunt, pacemaker leads, VSD occluder, transcatheter valve implantation. And as we now do more and more interventional valve implantation or VSD occlusion, we may start to see more of these cases. So the common organism, as I said, it can be staph, strep, Pseudomonas, Enterococcus, fungi, Hay-Sac, and on the left is the European data, and on the right is the US data. And so you can look up those papers if you are interested. So I think why I want to talk about SBE prophylaxis is I really want to know, because like my patient, she has no prior history. You don't know that. You can only have a high index of suspicion. So I don't think I can prevent her from having infective endocarditis. But for my congenital heart disease patient, they absolutely may be able to be protected. And so we may be able to give them SBE prophylaxis. So some of you may know we used to prophylax everybody. Just give them a dose of antibiotics an hour before dental procedure, you'll be fine. In 2007, there is a change in AHA guideline, and this is the rationale. They think that the bacteremia is from daily activities, meaning like brushing your teeth or something like that, pose a higher risk for IE than procedures like dental, GI tract, or GU tract procedure. And SBE prophylaxis may be minimally effective for preventing IE in such cases. And they want to risk the antibiotic-associated adverse events maybe outweighs the benefit. And they claim that maintenance of optimal oral health can help reduce bacteremia risk from daily activities. And we do stress that to our patient. Now, they do say that high-risk patients should still receive prophylaxis. So this was the 2007 AHA guideline. So they think that it is reasonable to give antibiotic prophylaxis for those with prosthetic cardiac valve or prosthetic material for cardiac valve repair, previous history of infective endocarditis, and certain group of congenital heart disease patients, unrepaired cyanotic heart disease, those with palliative shunt or conduits, completely repaired congenital heart disease with prosthetic material in the first 6 months. Or if they have been repaired with prosthetic material but still have a residual shunt around these material, and then heart transplant recipients. So they will give it to, is recommended if you are doing dental procedure that has some gingival tissue manipulation, teeth periapical region manipulation, or oral mucosa perforation. It is reasonable if you do respiratory tract or infected skin procedure, skin structure, or musculoskeletal tissue, but only for those with high-risk cardiac condition. Now, in the UK, they have this nice guideline, National Institute for Health and Clinical Excellence. In 2008, they also changed their guideline. So again, the high-risk patient, they don't argue with that, but they include hypertrophic cardiomyopathy patient. But in the NICE guideline, prophylaxis is not recommended for dental procedure and for non-dental procedure, like for GI tract, GU tract, gynecological, and obstetric procedure. So this is in huge difference from all other guidelines. So you might say, so that was back in 2007. What has happened and what is the impact of this change? And so this paper looked at in the US using nationwide inpatient sample, NIS, looking at the ICD-9 diagnostic code, identifying infective endocarditis as in patient under 18 years of age between 2001 and 2012. And they look at three things: the changes in the IE incidence, and they also want to analyze stratify by pathogen type between the younger age group 0 to 9 and the older age group 10 to 17. And then differences in the infective endocarditis severity assessed using inpatient mortality data and length of stay. So the good news is that there is no significant increase in IE incidence between the pre and the post era. So that's good. But if you look at the minutia, what is not good is that there is an increase in strep endocarditis after the guideline change, and especially in the Firaden strep after the guideline change. And there is a decrease in the culture negative endocarditis. So which is good, right? Probably, maybe because we're using less antibiotics, but we don't know that. So if you look more at the strep viridans data, actually in the younger age group, there is no difference in the IE from strep viridans. But in the older age group, there is a significant increase in strep viridans endocarditis. So why is that? So they postulated that Firaden strep, i.e. presumed to be stemmed from bacteria during dental work. Older children typically will have more dental visits than younger children. post-guideline change, there was a dramatic decrease in prophylaxis given for procedures in low-risk patients. So this suggests that the significant trend change was likely influenced by a shift in IE prevalence among the low-risk patient. So the good news is there is no significant difference in mortality and length of stay. But because they are using all these ICD coding, they are unable to obtain detailed data on incidence rates changes in at-risk children with congenital heart disease before and after the guideline implementation. And they have to assume that the proportion of at-risk children remain relatively stable. So that is a little bit of not great about this paper. And the limitation is that they identify it as primary, secondary, tertiary IE coding. And because they are de-identified, patients who were discharged and readmitted during a single episode of IE will be double counted. And the diagnostic coding practices may vary among different hospitals. And the reason for post-guideline rise in the Viridin strep IE in older patients really could not be determined, as antibiotic prophylaxis usage is not tracked. So what about that very dramatic, nice guideline changes? This paper look at that and look at the IE incidence in England. So they use the antibiotic prophylaxis prescribing data from 2004 to 2013, and they use the hospital discharge statistics with IE as a primary diagnosis between 2000 and 2013. Before 2008, they would give one dose of oral amoxicillin or clindamycin prophylaxis to patients with moderate and high risk. And what the outcome data they're looking at is the incidence data for IE and then the associated in-hospital mortality from the National Hospital Episode Statistics. So this blue line here represents the change. So you can see that the number of antibiotic prophylactic prescription definitely falls significantly with a very significant p-value. This is amoxicillin in red and clindamycin in blue. So there is a significant drop. And this is the antibiotics prescription by dentists in red and GPs in blue. So again, there's a significant drop. So they had over 19,000 patients with primary diagnosis of IE. 86% were emergency admission and 14% are planned admission. What do you mean by planned? Well, sometimes, you want to admit a patient, they may need to go home and grab their belonging or something. So it's a planned, semi-planned admission. So if you look at the population correlated incidence data, this is where is a little bit scary. So looking at the incidence in blue, there is this increase significantly by 0.11 cases per 10 million people per month, and the p-value is less than 0.0001. The mortality data is in red, and luckily this is non-significant, but there is still a slight rise of 0.01 cases per 10 million people per month, but the p is not significant. And so by March 2013, there are 34.9 more IE cases per month. And so this is quite significant. But they do say, because they're trying to save money, that you will need to have 277 prescription of antibiotic prophylaxis would be needed to prevent one case of IE. But nonetheless, with this data, I think they are going to look at the NICE guideline again. And if you look at the lower risk and higher risk patient, this is also scary. There is a significant increase in the IE incidence rate. And so you're not just talking about my high-risk congenital heart disease patient, but even in the lower risk group, this is significant. So the limitation of this data is that it relies on the UK hospital coding, and so you can't really generalize it to other population. And they use the ICD-10 and OPCS4 codes to identify the IE episode. But because of that, searches to identify previous IE episode, pre-existing congenital heart disease, operative procedures were very limited. And the data set also did not extend to before 2000. And the data for pathogen-specific causal organism coding was not available or unreliable. So we noted that the overall annual increase in the number of prosthetic heart valve and valve repair procedures over the study period. So there's a lot of confounding factor. So I think the conclusion that we know the prescription has fallen, but the incidence has increased significantly. But they are unable to use that data to prove a causal link. But because of that, in 2024, I know that the NICE is definitely looking at the guideline again. And so this is a summary of the 2015 SBE guideline prophylaxis. So the predisposing condition is fairly similar as far as regarding my congenital heart disease patient. But interestingly, in the NICE guideline, they include hypertrophic cardiomyopathy. And in the AHA guideline, they include cardiac transplantation. I wonder if that's because they also maybe have more transplantation than the other population. I don't know. And so for prophylaxis, in the AHA guideline is a class 2B for those who have highest risk group. You should give them to, you should consider giving antibiotic prophylaxis to these patients before dental procedure. In the ESC guideline, this is a 2A recommendation. Both have level of evidence C. So what is the implication for our clinical practice? I think prevention is still the number one goal. So I think even in my patient with low risk, we need to emphasize on oral hygiene. And in our high-risk patient, apart from oral hygiene, when they go to see the dentist, I will give them antibiotic prophylaxis. This comes from the European guideline. So in the moderate risk group, they will not give antibiotic prophylaxis. I have to say, when I practice in the U.S., and because it's instilled in me, is one dose of antibiotics. I've never had a problem with that. I will protect them. And so even in my moderate risk patient, apart from dental hygiene, I will still give them antibiotic prophylaxis. I think in low risk group, I think they do not need it. And the data from the impact data on the 2007 AHA guideline show that. For diagnosis, we talked about it already. You can use clinical evaluation, blood culture, multimodal imaging is important, and I think CT and even nuclear imaging is very important. Antibiotic therapy, you definitely want to talk to your infectious disease people to help you figure it out. There is a trend in Europe to consider outpatient oral therapy. And they may do that if they repeat a TEE, transesophageal echo at day 10, and meet these criteria, then they will consider outpatient therapy. I will tell you, in children, because IE is such a devastating event, and if they regress because of oral antibiotics, causing them to then need surgery, I don't think we will ever do oral antibiotics in my group. But this is the European data. And then cardiac surgery, you will consider it if you have heart failure, uncontrolled infection, or prevention of embolization, or obviously significant valve destruction, like in my patient. So you can have emergency, urgent, non-urgent, or I guess semi-elective, like in my patient. And so while I'm researching for this talk, I don't know if any of you know this. This is by the Hong Kong government. It's impact.chb.gov.hk. It is really a very nice guideline for a lot of empirical antibiotic therapy. And they even have empirical antibiotic therapy for subacute endocarditis and acute infective endocarditis while you're waiting for the organism to come back. And if you know what they are, these are the guidelines that they give you. And this is you can look at it online, and they actually also have an app on the iPhone that you can download. It's very useful. And this is our part of our cardiac team in children's. And I want to let you know that on the 13th to 15th of December, we have the Asian Congress of Pediatric Infectious Disease in Hong Kong. And the early bird registration deadline is on the 13th of October. So you still have time if you would like to listen to these distinguished speakers here. Thank you.
好，咁咧好多謝阿 Sabrina。咁咧呢堂書我諗好 timely 啊，即係嗱有幾樣嘢嘅。就第一個 nice guideline 即係香港考試都係跟嗰個啦嚇。咁照你所知喺香港咧我哋一般嘅 practice 我哋跟乜嘢？
唔係跟個 nice， 唔係
nice 啊，跟
因為我諗始終咧尤其是我哋係睇 congenital heart disease 啦。咁如果我哋嗰啲 prosthetic valve 啊或者 shunt 啊真係 get endocarditis 咧係真係嗰個 implication 係好大嘅，咁所以 I think we follow more like the AHA guideline。咁我覺得都係 reasonable 嘅，係啦。
第二樣我想問咧嗱頭先就講咗呢啲即係或者有之前有嘢或者之前冇嘢個心嗰度嚇，咁我哋即係我就做 neonate 啦或者 ICU 啦，我哋擺好多啲 line 落去嘅，呢方面你嘅 experience？
我哋見得多嘅咧，反而係多數係thrombus 啦。咁我諗，如果你一個人係 if they are septicemic and they are hypotensive and you need a central line， 咁你梗係要擺㗎啦。咁但係我諗，如果佢 septicemia， 你 treat 咗一排，如果你係 persistent positive blood culture 嘅，咁你都要開始諗下，我條 line 擺咗幾耐啊？咁其實我哋 PICU 喺兒童醫院都好proactive 嘅。如果佢真係咁咧，佢都會話：你哋 mind 唔 mind 同我哋睇睇嗰條 line， 你睇唔睇到啲嘢啊？咁但係個 limitation of transthoracic echo 咧，就係你越大個仔咧係越難睇嘅。咁所以你可以睇一個好 gross 嘅嘢睇到啦。但係如果你真係 high index of suspicion 咧，咁你可能真係要做 TEE 嘅。咁嗰個就大陣仗少少啦，係細蚊仔，因為你真係要 sedation 啊咁樣。咁所以我都會話你就咁 persistent blood culture 咧 is not alone。咁你都可以睇你嗰個 IE diagnosis 嘅 criteria 嘅。咁我覺得你第一你係 persistent blood culture 係乜嘢 blood culture 啦？有冇啲嘢係其他係差好多啦？或者點樣啊？即係你都要有個 criteria， 唔係話就咁做咗 echo 啦咁樣。咁即係因為如果係 negative 嘅 ，it doesn't rule it out either。因為你可能未睇到噶嘛，咁所以你都要跟嗰個endocarditis 嘅 diagnosis criteria 咯。
我哋我都記得有一段時間我哋都怕呢啲 line sepsis， 即係
係啊。
咁咧就有個諗法嗰陣時不如即係 regularly 幫佢做 echo 啦咁樣。你覺得有冇用？
咁我覺得又唔因為而家我哋 PICU 嘅 practice 咧喺佢哋嗰個 electronic medical record 咧，其實係有寫條 line 擺咗幾耐嘅。咁其實 coming 2 weeks 咧，佢哋每次 round 嘅時候咧，佢就會話我哋係咪真係仲需要呢條 line 咧？如果係需要嘅，我哋可唔可以換咗佢咧？咁樣咁如果換咗嘅時候，佢哋都會 send 個 line tip 去 culture。如果佢真係有咁嘅 suspicion， 佢會 send 去 culture 嘅，係咯。
但係如果真係要擺耐過，譬如2個星期。
咁佢哋會即係佢哋唔會要我哋照 echo， 但係佢可能就會抽翻 blood culture 咁樣咯嚇。因
為而家我諗好多 trainee 或者好多即係 resident 都 可以做 echo，bedside echo。你覺得呢個應唔應該加落個 care 嗰度？
嗱，我哋而家都有即係有 echo courses 教人啦。呢個係 two-edged sword。咁我覺得你如果係問美國咧，個 answer 會同呢個係完全唔同嘅。咁所以美國我哋話 no， 你唔可以做嘅，因為你係咪真係可以做到你係100%你自己可以話係冇呢個 vegetation 咧？咁所以佢哋係唔會承認嘅。咁喺香港咧，因為始終你唔可以話個個人都嚟兒童醫院叫我哋照啦，咁我哋都要 rely，and then 喺我哋 peripheral hospital 亦都有啲資深嘅 cardiologist 嘅，咁所以我覺得如果你係有 experience 去做嘅，咁你睇到當然係好好啦。咁我覺得你啱啱咁相反嚟講，我覺得你啱啱學完做 echo 嘅，你唔可以話我得嘅，一定係冇。我睇到係真係冇嘢嘅，即係我覺得你要有少少謙卑嘅心。即係我自己始終我都係 electrophysiologist 啦，我 echo 都唔係咁叻啦。如果我係真係擔心嘅，我都會叫我啲同事，喂，你可唔可以同我睇睇，真係 make sure 係咪真係冇嘢啊？因為我未必係做得最好嗰個嘅。咁我覺得你以為自己做得好好咧，其實可能第二個人嚟個手嚟到咧，睇到哇！個 echo 嘅 image 係原來可以靚咁多嘅喎，咁樣，咁所以我諗真係 high end suspicion 咯。
其他嘅 imaging 嗰啲 technique 又覺得點咧？
呢個係真係 practice makes perfect。咁同埋真係有陣時你要喐嚟喐去，你真係呢個你以為呢個 window 係喺呢個位睇嘅，有陣時真係，尤其是我哋 congenital heart， 佢哋啲 rotation 啊，完全唔同晒嘅。你有啲根本你平時唔用嘅地方，你都要去咯。咁所以我諗that's why I think echo 做得好嘅咧，係 is a very difficult skill。所以唔好以為你淨係學咗一次 echo course 咧，你就會做得好好咯。
其他 CT 啊、MRI 嗰啲有冇幫助？
喺 HA 你要攞到先咯。
如果譬如即係我當呢個 ideal
嘅，即係我諗都係要有咁大先至睇到嘅，因為你始終你 vegetation 如果係好細咧，係未必一定睇到。你要睇下佢 cut 到幾 thin 嘅 slice 啦。咁如果你越 thin 嘅，咁你 radiation 就越高啦。咁所以人哋你亦都要話俾個 patient 聽，咁佢亦都可能要打 contrast 啊咁樣樣。咁所以都唔係完全冇個 risk 喺度咯。
其他嗰啲譬如驗血啲 marker。
會嘅，我哋一定會做 CRP 啊、ESR 啊，但係 ESR 如果你 night time 咁你又做唔到啦。Procalcitonin 係好有幫助啦。咁同埋我諗你都要睇下佢有咩其他 organ involvement 咁樣。
咁喺你嘅經驗咧 ，natural cause of 個 infection 會點啊？譬如佢燒幾耐啊？佢唔舒服幾耐啊？幾時先至覺得？
嗱，佢呢個女仔就真係 on and off 成個月嘅，咁但係因為佢都係一個 otherwise 正常嘅女仔，同埋佢真係冇任何嘅之前做過任何嘢咯，咁所以佢就真係你如果要 astute 啲啦，咁我覺得第一嗰個 primary physician 已經 refer 咗去 clinic 噶啦，咁即係我諗住就係唯一一樣嘢佢可能可以做得再好啲嘅就係如果佢已經俾咗1、2次 antibiotics， 佢每次 recur 佢亦都知道自己聽到個新 murmur 嘅，咁呢個可能真係值得或者打電話嚟俾我哋，即係話喂可能我 refer 咗去outside hospital 嘅，但你哋會唔會兒童醫院心臟科可唔可以早啲見佢啊？咁我哋可能 even admit 佢 for 即係 evaluation 咁，即係 day center 睇佢啊咁樣樣咯。
咁譬如即係呢啲病人咁啦，即係我唔當佢係有 pre-existing 嘅 cardiac lesion，你會點樣 follow up 佢
？So 我哋即係你講好似呢個女仔咁。最主要就真係 clinically 嘅，佢有冇 heart failure symptoms 啦？咁我哋都會做翻 echo， 因為我哋都要 make sure， 譬如而家停晒 antibiotics 啦，會唔會有 rebound 啊？嗰個vegetation 會唔會大咗？如果係嘅，可能我哋要收翻佢入院啦，又可能要早少少做手術啦。而我冇講另外嘅 case 咧，就係一個 congenital heart disease patient 嚟嘅，咁嗰個就好 obvious，即係真係我哋聽慣啊，咁佢murmur大聲咗啊，佢個 valve dysfunction 又誇張咗啊，之前係冇嘅，咁所以呢個咧又係要等佢醫完之後，又係要做手術嘅咯。咁
頭先你講呢個即係 ultimate 可能佢都要做 valve replacement，而 家嗰個即係outcome 會點啊？即係如果做咗
佢就會 end up 要食 warfarin 噶啦，係啊，除非因為 left side valve 嗰啲 tissue valve 或者 bioprosthetic valve 咧，就係 last 冇咁耐嘅。咁所以 for 佢咧就我哋都有同 family 傾咗嘅，咁所以佢都係應該係會換咗一個metallic 噶啦。咁但係好彩佢因為佢都叫大個女啦，咁佢都應該可以擺一個 adult size 嘅 valve， 咁所以都應該可以 last for a long time。
通常幾耐要再換？
如果佢係冇任何 stenosis 啊或者 leakage 嘅，真係可能可以十幾廿年㗎，係啊。
都係一個好 significant 嘅 morbidity 嚟嘅。
係啊，因為你始終尤其是係女仔，如果你要食 warfarin， 你第日要懷孕嘅，咁呢個都係一個concern 嚟嘅，因為係 teratogenic 嘅。
咁我哋網上有條題目啦，都 practical 嘅。佢話都show children with high fever quite often have
heart murmur
嚇。How would you tell the difference from that of a new infected endocarditis murmur just from listening with the stethoscope？ 冇
可能噶啦，係啊，呢個冇可能噶啦，因為你可以有 full murmur 嘅啫嘛。咁你 full murmur，I think that's impossible to know。所以我覺得係你所以係要 repeated checking 咯。譬如你話係因為 fever 佢 tachycardia，佢有少少 anemia 而有個 full murmur 嘅，咁佢應該 fever 落咗，心率慢咗。你個 murmur 應該唔喺度啦，或者細聲好多咯。咁你如果係，咁你呢個係 is a feature of an innocent murmur, right? It changes according to the condition. 咁所以我諗 again is from experience and from serial examination。
不過頭先你講得好好咧，就係最緊要我哋唔好記得有呢個 diagnosis。
係，
即係我哋 student 嗰時就好記得，因為嗰時好多 rheumatic heart 啦，咁咧就同埋即係一定個 differential 一定有呢樣嘅。但係 as time goes on 咧，就可能即係就 shift 咗去其他啲病嗰度。咁我諗最重要就係 highness of suspicion 啦。係啊，即係如果即係都有問題，都係要即係請人幫手，即係睇下個心有冇嘢啊咁樣。咁呢個 case 你頭先個 case 真係 illustrate 得好好嘅嚇。咁其實香港咪真係咁少？嗱，頭先你又 call 咗有2個啦。係
啊，其實唔係少嘅，同埋我哋最近 even 我哋 congenital heart disease 嗰個咧，都係冇一個inciting event。只不過咧係我哋聽到佢即係咁樣好似大聲咗啊，咁啊同佢做個 echo， 咁就見到佢echo finding 係差咗。咁你真係再睇咧，就好似有個 vegetation 咁樣。咁所以我哋先話，咦，佢係有 endocarditis 喎咁樣。咁所以即係最近可能都2-3個係咁噶啦，係啊。
咁頭先講個 prophylaxis 嗰度咧，我仲記得嗰陣時我哋都即係我仲喺醫院做嗰陣時，我哋就有啲 guideline 啊，有啲 checklist 我哋。同埋有啲信我哋印咗，因為好多人都 refer
我哋都有嘅，而家都有嘅。係，我哋都所有我哋 high risk、moderate risk 嗰啲，我哋都會俾佢嘅。咁甚至如果佢就快去睇牙醫嘅，我哋如果嗰日覆診都可能開埋1劑俾佢嘅。
咁其實頭先你講牙醫，其實牙醫都要知喎，即係
係㗎，係啊，啱啊。佢哋都其實大部分牙醫都知嘅。
係啊，佢哋有好多時會寫嚟問我哋啊，
係啊係啊，
可以點做啊咁樣。
係啊，
所以我諗呢堂書我都會推介俾啲牙科醫生嚇，因為遲啲應該4月我哋會有嘅，因為牙科醫生都講個 talk 嚇，不過未 finalize 啊，咁我哋又會講啊，咁咧今日就唔係太多問題，因為你講得實在太清楚明白。咁但係我諗呢個好 timely， 我諗即係大家都要即係知道，唔好唔記得有 infected endocarditis 呢樣嘢。嗱，咁頭先你仲講一樣嘢就係佢有啲 Marfan嘅 features。
係啊。
咁 Marfan 嗰啲個 risk 有幾大？
嗱，因為嗰個如果你係有 Marfan 咧，你係可以有 mitral valve prolapse 嘅。咁所以其實你可能你個 mitral valve 係 abnormal 嘅。咁但係唔知啦，因為佢咁細個做嗰個 echo 唔係我哋做嘅，咁個 parents 淨係話個 report 話係 normal 喎咁樣，咁我即係冇辦法可以追翻嗰啲 echo images 㗎啦。
我知你就除咗小朋友嗰啲病咧，嗰啲小朋友講張黑你又會去到大人嗰度。嗱，你如果講 mitral valve 咧，我最近都聽話有啲 mitral valve 即係大人有啦，我哋即係唔係 handle 到，即係佢哋都好多 mitral incompetence 嘅。
係啊係啊。
嗰類嘅病人又係咪 at risk for 啲
Well, I think 大人好多時候好多其他嘅 comorbidities 咯，即係未必一定因為淨係你個 valve 咯，即係你係咪多數大人嘅牙齒有冇咁健康啊？即係佢都有好多其他嘅因素嘅。
但係佢係多啲 risk 嘅，即係如果
佢嘅係我諗佢有少少啦，但係係啊，因為佢點解你而家聽得多咗？因為佢有啲 mitral valve clip 嗰啲 procedure，咁所以可以幫手做嘅。咁但係其實 as I said，你而家越嚟越多呢啲 interventional 嘅嘢咧，其實我哋都要睇下 downstream 會唔會呢啲人係會有多咗問題啦。咁暫時我都即係如果啱啱做完，你一定會俾 SB prophylaxis 噶啦。咁但係譬如你話 ASD 啊 PDA device 6個月後，我哋就話唔需要SB prophylaxis， 因為應該係 endothelialize 咗嘅。咁但係我真係唔知，如果你話你擺個 clip 喺個 mitral valve 係成日個 valve 喺度喐嘅，佢會唔會都係 endothelialize 咧？同埋你一路都會有 high amount of blood flow across 呢個 foreign body 嘅，咁你會唔會係高啲風險咧？唔知啊。咁同埋我哋嗰陣時我哋而家啲 transcatheter 尤其是大人就 aortic valve 啦，我哋就 pulmonary valve 啦。咁其實佢都有個 study 都話好似 Sapien 同埋Edward valve 其中一個好似多少少啊咁樣樣。咁所以呢啲都要睇住嘅。
係咯，我諗大家都要留意，即係呢個都唔係淨係小朋友嘅病，即係做大啲又會多啲。係啊 interesting 呢個。係啊。嗱咁咧就頭先講緊呢個話題咧，我而家就約你。遲啲咧嚇，即係可能半年後咧，你真係要幫我哋講下呢啲 congenital heart disease 嘅小朋友咧，大個你點樣打理？呢個你嘅 expertise 嗰度，咁咧我都好渴望聽到，因為好多同事都會問嘅，即係 transitional care。咁我哋試過以前都有一堂書係講 transitional care，但係即係我諗in specific， 即係你嘅 expertise 就係。呢啲細路仔其實 grow into 即係 young adult 或者將來到 adult， 其實佢哋點樣樣咧？我諗作為個兒科醫生，我哋都要識嘅，因為父母都會問。係。咁我希望下一次咧，而家約定你先嚇。好。下一次你嚟咧，你就幫我講呢個即係 management of 呢個 congenital heart disease 而呢個 adulthood 咁樣好。好啊好啊好啊。多謝阿 Sabrina。Thank you thank you。我海邊有個紀念品。哦 thank you thank you。第二個啦你。多謝。